Next. So what is fever without focus? Fever without focus means it is an acute fever lasting less than 7 days without a clear focus after a complete clinical examination. That is the definition of fever without focus. That is a fever which lasts less than 7 days without a clear focus after a complete clinical examination. We know that it is a challenge for clinicians as infants and children may come with non-specific symptoms and their clinical presentations can vary and it is very difficult to identify such clinical symptoms. Next. So we know that most of the fever without focus have a good prognosis as majority are self-limited. Majority of the fever without focus will be some self-limited viral illness as viral illnesses are more common after the COVID era. Now there is a flu epidemic and also there is coming back of COVID also. So most of the fever without focus have a good prognosis as majority are self-limited. But 1 to 30% have severe bacterial infections such as urinary tract infections, severe sepsis or bacteremia. Rarely there may be chance of meningitis. So we have to identify the severe bacterial infections, that is 1 to 30% which causes severe comorbidities and severe infections in the children. Next. So who are the children are at risk of serious bacterial infections? So we know that the newborn, the age less than 3 months, it is very difficult to identify their symptoms. Most of the children without a non-specific symptoms, only with fever. So age less, the children, infants are more at risk for serious bacterial infections. And also immunocompromised children. There is so many immunocompromised children. There the proportion is less. The immunocompromised children are at high risk of serious bacterial infections, and children with malignancy are also with high risk of infections. The children with post-transplant children who is on long-term steroids are also at high risk for infections, and some children with nephrotic syndrome with long-time steroids are also high risk for serious bacterial infections. And in children with serious chronic medical conditions, the children with congenital heart disease, the children with chronic kidney disease, the children with chronic liver disease, these children are also at risk for serious bacterial infections. And nowadays, the children with intellectual disabilities and preterm babies and children with chronic neurological conditions also are presenting to our OPD. These children, the preterm babies, the children with intellectual disabilities like ADHD children or seizure disorder children or progressive any neurological disease children and chronic neurological conditions also are at high risk of bacterial infection. So these are the children, that is age less than 3 months, immunocompromised children, children with serious chronic medical conditions, and children with intellectual disability and chronic neurological conditions are at high risk for serious bacterial infections. Next. Next slide. And in children between the age group of 3 months to 36 months, the fever without focus is mostly the self-limiting viral illness. So it is as it is the 70% is mostly self-limiting viral illness. And we know the age group which is there is more vaccinations are coming in the UIP period. There will be post-vaccination fever. It is also common. But the characteristic of post-vaccination fever, it is typically lasts for 24 hours. So that's why we are prescribing paracetamol or analgesic, or if we are giving the pertussis component vaccines like pentavalent vaccines or DPT, etc. So post-vaccination fever is common in children, which the characteristic it is last only for 24 hours. And other common illnesses between the 3 months to 36 months, that is the urinary tract infection. That is the most common fever without focus infections in children between 3 to 36 months. The characteristic UTI, the temperature is high grade. It is more than 102 Fahrenheit. It is the most common. It is 8 to 10% cause of fever without focus. And there is chance of bacteremia is also there in children in this age group. In bacteremia also, the temperature is lasts more than 102 degrees Fahrenheit. In completely vaccinated children, that is, it is bacterium is very rare. It is less than 1%. After the introduction of Hib vaccination, that is the pentavalent vaccination, and PCV vaccination, the bacterium is comparatively very less. In fully vaccinated children, it is less than 1%, and it is 3 to 11% in non-vaccinated children or partially vaccinated children. That is particularly those children who missed Hib vaccination. That is also a component of pentavalent vaccination, and also the pneumococcal conjugate vaccine. In non-vaccinated and partially vaccinated children, the incidence is 3 to 11%. Compared to the fully vaccinated children, that is the incidence is less than 1%. And even if the pneumonia may present with clinical signs, sometimes focal pneumonia without may be missed. The clinical findings can be missed. It may also present with fever without focus in in children between 3 to 36 months. And in this children, there is chance of rarely osteomyelitis, chance of septic arthritis is also rarely the cause of fever without focus. And meningitis is also a cause for fever without focus in children. Incidence is very less after the introduction of Hib and PCV vaccination. We are rare now. Very rarely we are seeing meningitis with Hib and Haemophilus influenza pneumococcal vaccines in completely vaccinated children. So these are the causes of fever without focus in the age group of 3 to 36 months. Mainly the majority is viral illness, post-vaccination fever, UTI, bacteremia, focal pneumonia, osteomyelitis, septic arthritis, and meningitis. Next slide. Next. So how we can approach? So from history, whether we have to ask the parents whether the fever is documented. Sometimes they will complain of fever. There will not be any documented fever. So we have to ask whether the fever is documented. In this era, majority of the parents have thermometer, digital thermometer. They are documenting the fever. So whether they have documented the fever, and also we have to ask for the daily activities. Daily activities, whether the oral intake of child, whether the child is taking the breastfeeds, whether the child is taking oral water and oral feeds. We have to ask for the cry of the child, whether the child is crying the normal cry, or there is decreased cry or decreased activity. And we have to ask specifically for decreased movement of any limb or any joint, to look for any features of any septic arthritis or any osteomyelitis, etc. And also we have to ask for any difficulty in walking. Sometimes after the post-vaccination, also there may be some difficulty in walking. And if there is any joint lesions or joint infections, there may be a difficulty in walking. So we have to specifically ask for the joint symptoms also. And irritability or lethargy. If the child is more sick, the child may be irritable, child may be lethargic. If there is any CNS infections also, the child will be more lethargic or irritability. So we have to ask for the irritability, lethargy, the grade of awakeness, etc. While we are eliciting the history. And the immunization history, as I mentioned in the previous slide, there may be post-vaccination fever is common in this age group. So we had to ask for the immunization history. And also we have to specifically ask for whether they had received Hib vaccination or PC vaccination. They are fully vaccinated or partially vaccinated. And in older children, there may be history of foul smelling urine. There may be dysuria, and there may be increased frequency of urination. So that may be the symptoms of UTI. So in older children, we can specifically ask for the dysuria, foul smelling urine, or frequency of urination. And also we have to ask the history suggestive of any chronic medical conditions. The history suggestive of congenital heart disease, like any bluish discoloration of skin or any cyanosis, any exceptional dyspnea. In in chronic liver disease, we have to ask for any history of jaundice or pale color stool. And chronic kidney disease, we have to ask for a pedal edema or a decreased urine output, etc. So we had to ask for any history suggestive of any chronic medical illnesses. And we had to ask for specifically the evening rise of temperature and cough, which suggestive of any tuberculosis, etc. And not gaining weight or there is weight loss, suggestive of any chronic illnesses. And also some history suggestive of any malignancies like long lasting, there is no weight gain, there is long duration of fever, etc., which may size some malignancies also. So history is very important in eliciting the fever without focus. Next slide. Then the clinical examination, we have to the clinical examination should focus whether we can either locate any infection, whether we can focus any infections in somewhere in the uh, examination, suggestive of any clinical lesions. So we had to look for in oral cavity. We had to look for the oral cavity. We had to look for any lesions in the oropharynx and larynx. So we know that herpetic ulcers, which may present with fever without focus, there will be sometimes there will be anterior ulcers, and Coxsackie virus, which is most common in causing the HFMD, hand, foot, mouth disease. There may be pharyngeal vesicles, and there may be associated vesicles in the palm, buttocks, and lower limbs, and etc. So we can look for any vesicles, and there may be associated vesicle like any dewdrop on petal like lesions in chickenpox or any other rashes like any river in the body, etc. So we had to look for any vesicles or any ulcers in the oral cavity, and we had to look for any pain with bone palpation or any there is any passive range of motion, there is any difficulty in moving any joints, and we had to look for any peteke, any cellulitis or viral exanthemal rashes in the body. So peteke may be seen in meningococcemia or any rashes, cellulitis or any pyoderma. There will be some infections which may be mixed in the clinical examination, and any viral exanthematous fever. And we had to look for any bulging anterior fontanelle in children, in infants, which may suggest you of any meningitis or any CNS infections. And look for tragal tenderness, that is ASOM also common in the age group in the infancy, which we may miss. So we have to look elicit tragal tenderness, and which may suggest you of any ASOM, acute suppurative otitis media. And we have to undress the child and look for any tachypnea. There is sometimes we may miss any occult pneumonia, etc. So we have to undress and look for any tachypnea and either any chest drawing, etc. So these are the main important clinical examination. And per abdomen, we have to look for any tenderness in the lower abdomen, which may suggest any QTA also. So these are the main important clinical examination in focusing fever without focus. Next slide. So as we discussed in herpes, there is ulcer in the anterior part, that is in the tongue and the anterior part. There may be ulcers. It is seen in the herpetic ulcer. We have to examine the oral cavity and we can see some herpetic ulcer. In Coxsackie virus, that is in the HFMD itself, the ulcers is mainly located in the posterior pharyngeal wall. So that is characteristic of an HFMD, that the lesions are mainly in the posterior pharyngeal wall. In herpes, mainly the anterior ulcers are seen. Next slide. And in assessing the severity of the fever without focus, there is a guidelines, nice traffic light system through which we can assess the severity of fever without focus. And in traffic, like in the traffic light system, there is characterized into green, that is the lower risk, amber, that is the intermediate risk, red, there is high risk. So we had to assess the children based on this traffic light system. The color of the children, whether the color of the child is normal. So it is mentioned that the child is in the green, that is the low risk zone. Amber, that is intermediate, that there may be sometime there may be pallor. So we have to assess the child is somewhat sick. And red, that is high risk. We have to refer the child in case of the child is pale or motile, if the child appears blue. In that case, we have to assess that child is sick. And activity, based on activity, if the child responds normally to a social cue, we know that the social smile appears in the third month. So whether the child is not socially responds to our social cues, there is no social smile. The child is not responding to our social cues. So we had to assess. So if it is low risk, the child is normally responds to our social cue. the child is stay awake, the cry is normal. If it is child is somewhat intermediate risk, if the child is not responding normally to the social cue, the social smile is absent. The child wakes only with prolonged stimulation. If we stimulate the child is wakes and decreased activity. So we have to make sure that the child is somewhat sick. That is the amber, that is the intermediate zone. In red or high risk zone, if the child is not responding to the social cue, child is does not awake or stay aroused if awakened, child is not and the child is does not awake or stay aroused if awakened. The cry is weak or continuous cry. We have to assess the child is in the high risk zone. And in respiration, we have to assess in the green risk the child is in normally respiring, that is in the green, that is low risk. If there is nasal flaring, if there is tachypnea, we can assess with the age group between less than 2 months, more than 60 per minute respiratory rate, it is tachypnea. 2 to 12 months, if the respiratory rate is more than 50, it is tachypnea. From 1 year to 5 years, if there is more than 40 per minute, there is tachypnea. So we can assess the child based on these factors, and on examination, if there is any crackles or crepitations present, and if the SpO2 is less than 95, we have to assess that the child is in intermediate risk. And if there is grunting, the child is having grunting, if there is any chest indrawing, if the child is tachypneic, we have to assess that the child is in impending respiratory failure. We have to refer the child with oxygen or any after giving the first dose of IV antibiotics. Next slide. And in assessment of circulation and hydration, in the green and low risk, the child's skin and mucosa will be normal skin and mucosa. The mucous membrane is moist. And in intermediate risk, that is amber intermediate risk, that the child, if the child is having tachycardia, that is more than 160 per minute, if the child is less than 12 months, more than 150 between 12 to 24 months, more than 140 in 2 to 5 years. If the heart rate is more than this range, there is an intermediate risk, and capillary refilling time, it is more than 3 seconds. And if the child is poor feeding, there is reduced urine output. Also, we have to assess that the child is in intermediate risk. We have to intervene that time. And if the child is in shock, if there is reduced skin turgor, we can examine around the abdomen. The skin is going back so fast if there is no dehydration. If the skin is going very slowly, we have to assess the child is in severe shock or dehydration. Next. And in case of other signs, if there is temperature is more than 39 degrees centigrade, the fever is lasting more than 5 days, if there is rigors, swelling of a joint or limb, and if there is limping while walking, the child is not wearing weight on any particular limb. So we have to assess that the child is in intermediate risk. If there is red, that is the severe risk. If the child is less than 3 months, temperature is more than 30 degrees centigrade. If there is rash, bulging fontanelle, neck stiffness, if the child is having seizures, if there is any focal neurological deficits or focal seizures. So based on these findings, that is the nice traffic light system, we can assess the child. We can assess whether the child is in risk, intermediate risk or high risk. Next slide. So based on this classification itself, we can proceed that if the child is active, the child is not sick. If the child is cry and activity is good, the child is responding well to normal cues. The first investigation we have to look is the urine routine. That is the most common cause of fever without focus in children. 8 to 10%, it may be urine routine. So first investigation we have to do is the urine routine. If the child is in amber colored, that is the child is moderately sick, we have to do an investigation like CBC. We look for the counts, whether it is leukocytosis, the type of infection, whether it is neutrophil predominant or lymphocyte predominant. And we can also assess the severity of infections and inflammation based on CRP. If there is any infections, we have to send in blood culture in case of any infants less than 3 months. And if there is any bulging fontanelle, the child is not responding, there is symptoms history of any meningitis, we have to look for lumbar puncture if the child is less than 1 year. And after doing the blood investigation, and the total count is more than 20,000, even in the absence of respiratory symptoms, we have to take a chest X-ray whether to look for any pneumonia. We may miss any occult pneumonia. So in that case, we have to take a chest X-ray also. So if the child is in intermediate risk, we have to start with first we had to do urinary protein, then CBC, CRP, blood culture, and if there is symptom suggestive of any meningitis, we had to do any LP also. And if the total count is more than 20,000, even in the absence of respiratory symptoms, we had to take a chest X-ray. And in the severe category, the sick category, we have to admit the child, and we have to do all the investigation like CBC, CRP, blood culture. If procalcitonin, it is also an acute phase reactant and acute inflammatory marker. If it is available, we have to look, and we have to do urine routine and LP if the history suggestive of any history or clinical examination suggestive of any meningitis, and chest X-ray, serum electrolyte, blood gas to assess the oxygen status, and also any acid-base imbalance. And we had to look for LFT, RFT also. If there is any history suggestive of any viral infections, we have to take any throat swab to look for any COVID or etc. or throat swab or nasopharyngeal swab to look for any COVID or flu also, H1N1 also. Next. So the management also, we have to assess the child based on whether it is well child or ill child. In case of any well child, first we had to record the temperature and look for any focus. In management also, we had to first we have to record the temperature and again re-examine and look for any focus. Sometimes the clinical features may present in the later days, and we have to follow up the child. We have to follow up the child, and we can investigate after 24 hours. If this child is well, we can follow. We are sure that the child may come next day. We have to follow up the child after 24 hours. Then only we can start the investigations. We can start on antipyretics. The common antipyretics we are using, we know it is paracetamol in the 10 to 15 milligram per kg per dosage, or we can use an ibuprofen 5 to 10 mg per kg per dose. And we have to ensure that the child is getting proper hydration. We have to counsel the mother that the child should be breastfed, and the child should get enough water. And less than 3 months, if the child is sick, we can investigate based on the clinical assessment on the same day itself, because the clinical features, clinical symptoms may not be so apparent. It may be atypical. So if the less than 3 months, if the child is, even if the child is well, if we need any assessment, we can assess on the same day. If it is more than 3 months to 3 years, if the child is well, we can give paracetamol and ensure hydration, record the temperature. We can call the child for the follow-up on the next day. Next slide. If it is an ill child, based on the category, if it is an ill child, we have to record the temperature. Again, we have to look for any focus, and we have to give the investigations as in the red category: urine routine, blood routine, CRP, procalcitonin, or chest X-ray, and blood culture, etc. And we have to monitor the child's SpO2, BP, respiratory rate monitoring also. And we can start the antipyretics, paracetamol, ibuprofen, etc. It is ibuprofen if the fever is not subsiding with antipyretics. And we can start IV antibiotics empirically. If there is no focus infection, the most common antibiotics empirically we start injection ampicillin or injection ceftriaxone. And also we can start any gram-negative or gram-negative coverage. We can add injection amikacin also. If the clinical features and suggestive of any viral infection, if it is suggestive of any H1N1, etc., we can start antivirals, oseltamivir, etc. And we have to ensure the hydration. And if the child is in shock, we can start IV fluids, normal saline. If it is in shock, we have to start 20 ml per kg, and we can maintain the IV fluids based on the holiday Sagar formula, or minimum we can give a 10 ml per kg or 20 ml per kg, 20 ml per kg if there is a shock, and we can start the maintenance fluid based on the holiday Sagar formula. And if it is child is in the periphery or it is in the first level of center, we have to refer the child for the further evaluation and management. If it is in the tertiary center, we can based on the findings, we can manage here itself. That is the management protocol. If it is a child is ill child, first we had to record the temperature and we had to again assess the child, and for any focus we had to start antibiotics, IV antibiotics based on the clinical and lab values and antivirals, etc. And also we had to ensure the hydration, and we can start IV fluids and refer the child as well. Next slide. So what are the red flag signs of any child we are coming to us in the OPD? As I mentioned, the pale motile skin, blue skin or lips or tongue. The child appears ill. There is no response to social cues. The respiratory rate is very tachycardic. It is more than 60 per minute. If the child does not awake, do not stay awake if aroused. If the child is having grunting, the child is having the cry is weak or high pitched cry. If there is chest indrawing, if there is reduced skin turgor, if the bulging fontanella is present, which may suggest of any meningitis or any CNS infection. These are the red flag signs. That is, we can assess the child based on these red flag signs. If the red flag signs is present, we have to intervene at the early, and we have to refer the child as early as possible. Next slide. So the key points: the fever should be documented, and history and clinical examination to be repeated every visit to identify a focus. And as we know, the majority, that is 70% it is self-limiting, mainly the viral illness, but we have to look for the 30%, mainly the UTI, bacteremia, pneumonia, and any CNS infections like meningitis. So we have to start with urine routine in a well child, then based on the assessment and grading of symptoms, as I mentioned in the NICE grading, and methodological screening and assessment using the NICE traffic light system. And we had to, the most important point in this era, in the medical legal era, we had to counsel the parents well, proper counseling, and we had to properly communicate the illness to the bystanders. We had to ask them to wait for 1 day. If it is child is sick, we had to refer promptly as per the clinical assessment, and we had to admit the ill child, or if we are referring, we had to give a first dose of any IV antibiotics if there is pneumonia or any bacterial infections, and we have to refer the child if needed after stabilizing the child. These are the key points while approaching the fever without focus. So I had main references, standard treatment guidelines of central IAP. That is the guidelines I had referred. So that's in nutshell about how to approach a fever without focus. If there is any questions, I'm ready to answer. Thank you.
Thank you, Ranjith. Topic is open for discussion.
രഞ്ജിത്ത് ഡോക്ടർ ഒരു ഡൗട്ട് ചോദിച്ചോട്ടെ. ഹലോ,
ചോദിച്ചോളൂ.
നമുക്കിപ്പോ ഈ ആന്റിബയോട്ടിക് സ്റ്റാർട്ട് ചെയ്യുന്നതിന് അങ്ങനെ വല്ല എന്താ പറയാ സ്കോറോ അങ്ങനെ എന്തെങ്കിലും പ്രത്യേകമായിട്ട് ഗൈഡ് ലൈൻസോ അങ്ങനെ എന്തെങ്കിലും ഉണ്ടോ അഡ്മിറ്റ് ചെയ്യുന്ന പേഷ്യൻസിന്?
ഇപ്പൊ നമുക്ക് പിന്നെ ഇപ്പത്തെല്ലാം ചില നമ്മള് ഇപ്പൊ മെയിൻലി വരുന്നതെല്ലാം ഫ്ലൂ ലൈക്ക് സിംറ്റംസ് ആയതുകൊണ്ട് നമ്മള് വിത്തൗട്ട് ഫോക്കസ് നമുക്ക് ഫസ്റ്റ് ഡേ ഒക്കെ നമുക്ക് ആന്റിബയോട്ടിക് സ്റ്റാർട്ട് ചെയ്യേണ്ട ആവശ്യം വരില്ല. നമ്മൾ എന്താണ് കോസ് എന്ന് നോക്കിയതിന് ശേഷം അപ്പൊ നമ്മൾ നോക്കി ഇപ്പൊ മെയിൻലി കാണുന്ന സിംറ്റംസ് എല്ലാം ഫീവർ, മയാൾജിയ, സോർ ത്രോട്ട് അങ്ങനെയുള്ള സിംറ്റംസ് ആണ് നമുക്ക് അധികം വരുന്നത്. അപ്പൊ നമുക്ക് വിത്തൗട്ട് റെസ്പിറേറ്ററി ഫോക്കസ് നമുക്കൊരു കൃത്യം ഒന്നും കിട്ടുന്നില്ലെങ്കിൽ നമ്മൾ മെയിൻലി സിംറ്റമാറ്റിക് ആയിട്ട് നമുക്ക് കൊടുക്കാം. ഫീവറിനുള്ള മാനേജ്മെന്റ്, അല്ലെങ്കിൽ കോഫിനുള്ള മാനേജ്മെന്റ്, ഇനി ബ്രോങ്കോ ഡയലൈറ്റേഴ്സ് നമുക്ക് കൊടുക്കാം. അത് കഴിഞ്ഞ് നൈസൽ ഡ്രോപ്സ് പോലെ എന്തെങ്കിലും നമുക്ക് കൊടുക്കാം, അല്ലെങ്കിൽ ഡീഹൈഡ്രേഷൻ കറക്റ്റ് ചെയ്യാൻ വേണ്ടി ORS പോലെ കൊടുക്കാം. എന്നിട്ട് സെപ്പറേറ്റ് റിവ്യൂ ചെയ്യാൻ